Hello nurses, this is Kevin with Nursing KAMP.com, and these are my scribble notes on nursing and the NCLEX. Today's focus is on pulmonary lecture number 18, Hypoxemia and Hypoxia. From this sticky note found on Nursing Camp, social media, Pinterest, Facebook, and Instagram. All right, let's get into it. All right, when we're talking about hypoxemia and hypoxia, we're talking about basically problems with oxygenation in the bloodstream. And oxygenation in the bloodstream could be affected by a lot of different conditions, like hypovolemia, CHF, there's a pump problem, vascular disease, where there's a vascular problem, or pulmonary conditions, like a COPD or bronchitis, emphysema, pulmonary fibrosis. There's actually a ventilation problem. And this is called ventilation versus respirations, and or a VQ mismatch. And VQ mismatch is ventilation versus quality of the ventilation. We're going to talk about that in another lecture, but what we're talking right now is about the results of hypoxemia that results into hypoxia and the signs and symptoms of hypoxia. Well, we talked about earlier, earliest signs, and earliest signs is the boat coming. And what I mean by the boat coming is the boat is problems. And what these problems are things that happen before an acute situation. This is the boat coming, and that means that the problem is coming. Once we talk about the later signs is the boat is here, and it is an acute problem. So when we're looking at the boat coming, we're looking at, why is a patient that is sitting in the bed with tachycardia, for example, at 86 or even 90? Why is a little old lady heartbeat running at 90 beats per minute? So that's the boat coming. Now, the boat here is 120 heart rate. Anybody can see a 120 heart rate and say, hey, that's a problem. So always look at the signs and symptoms in an NCLEX question to recognize whether assessment, as in the boat coming, is needed, or intervention as far as the boat is here, like heart rate is 120. All right, so let's talk about tachypnea. Now, tachypnea is rapid breathing, rapid, fast breathing. So if you think about this, if there's a problem in the lungs, like pneumonia or a pneumo, there's air in the place, or a hemo, or a COPD, emphysema, what happens is it's interfering with the oxygenation and the blood flow. So what happens is they start to breathe faster. And we talked about this before. Respirations are generally 16 to 24. Once the respirations get greater than 24, that means that there's something acute going on. 24 to 30 is definitely the boat coming. Right? Greater than 30, the boat is here. Because we're in what's called acute respiratory distress. And so what happens is the body starts to compensate by increasing its rate of breathing, or tachypnea. All right, so then the next thing is, because the body's not getting perfused, you start to have increased heart rate, 90s, 100s. And that means that the body's trying to compensate because it's not getting oxygen, so it starts to increase the heart rate. Because there is a decrease of perfusion, in my previous lecture I talked about restlessness, you start to see this restlessness, and that becomes acute. With anxiety, so restless to anxiety. And then what you actually start to see is that person starts to get pale, and the pallor, because you start to see shunting going on, and you start to see decreased perfusion, and everything starts to go to the heart, the core, the heart and the lungs. And please see my lecture on parasympathetic versus sympathetic system. All right, so then we have actually an elevated blood pressure. Now, the reason that this happens is that when the excuse me, when the blood is not getting, or the oxygen is not getting to the fingers and toes, what happens is that the vessels start to vasoconstrict. In turn, increases the blood pressure. This vasoconstriction is actually SVR, systemic vascular resistance. Please see my lecture on SVR. But basically what happens is the body sets to clamp to increase the blood flow back to the heart. Next is shortness of breath, obviously. Patient is shortness of breath. All right, so you can basically take any of these signs and symptoms and put them in the beginning part of a question. Patient's admitted with COPD and has tachypnea. What's nursing priority? Well, put them in high followers. Patient has a COPD, has tachycardia with tachypnea. High followers. So these are all problems that end up becoming the boat coming before. So these are the problems that we see before that usually requires further on assessment. Because as the patient starts to decompensate, you start to see the later signs. All right, so let's get into the later signs. Now, when we start to see confusion is a problem. And that confusion is because of decreased perfusion. Now, we talked about in a previous lecture that blood pressure has a mean arterial pressure. And a mean arterial pressure is for perfusion. And when I'm talking about perfusion, I'm talking about blood flow and oxygenation. And mean arterial pressure needs to be greater than 60 to 65 for the kidneys. Because if you don't have perfusion of the kidneys, you'll see decreased urinary output. That's if the blood pressure is low and the mean arterial pressure is 60-65. But the interesting thing is that for a patient to perfuse their brain, they need a mean arterial pressure greater than 70 to 75%. Because if it's not greater than 75%, you're going to start to see restlessness, anxiety, then confusion. And orientation basically goes from, we lose it from time, place, then person, in that order. We generally lose track of time, person, place. So confusion, disorientation becomes a problem. Stupor is definitely somebody who's lethargic and can't be aroused. Now they start to shut down. Bradypnea. So we talked about that before. Remember, 30 to 36, that's acute respiratory distress up here. But once they start to go down to like 14, so if you have a respiration that's going from 16 to 14, that's a bad sign. That means that the patient's in failure, acute respiratory failure. And I'll talk about that in my next lecture. So we know that 14 is bad, then it goes down to 10. 10 is always a problem, and then 8 is intubate. That patient should be bagged or intubated. Hypotension. Why does a patient get hypotensive? Because we know that elevated blood pressure is there. So what happens is that as a person starts to decrease their respirations, they start to increase their CO2. And the CO2 gets into their body, and then what happens is from the increased CO2 is they vasodilate. So the blood pressure, once in the presence of CO2, vasodilates. So the blood pressure actually starts to decrease. And then cardiac dysrhythmias, because that affects the calcium and potassium channels, and leading to VTAC, VFib, peak T waves, and so on. Definitely dysrhythmias. Ischemia tends to be ST depression first. All right, that's a general overview of hypoxemia and hypoxia, the result of early signs to later signs. And this opens up our next stage of, we're talking about acute respiratory distress versus acute respiratory failure. All right, my name is Kamp, and this is Nursing Kamp, and this is NCLEX Kamp and Pulmonary Kamp. A lot of camp going on. We'll see you next time. Nurse on.